Okay, so I am sitting with Dr. Kovanchi, who is a board certified reproductive endocrinology and infertility specialist with over 10 years of experience. He completed his postgrad education at prestigious institutions such as Yale University and Baylor College of Medicine, where he also served as assistant professor at Baylor for several years. He has co-authored multiple scientific studies on reproductive systems in the world-renowned journals. He has also been a co-investigator for several NIH-sponsored research projects and has been invited to lecture at national and international conferences and meetings. So I actually know Dr. Kovanchi personally, as I saw him when we were beginning the journey to parenting, and we just wanted to make sure everything was working and everything was what it was supposed to be. And so we were introduced by a friend, and we saw him at his practice when he was based in the medical center in Houston, and we really had a great experience. So welcome, Dr. Kovanchi.
Thank you. Thank you for having me.
All
Great
right.
to see you again.
Good to see you too. So we're just going to go ahead and get started with basically a broad overview. I'm going to ask you some questions and also some viewer questions and listener questions, and just kind of explore the whole fertility and infertility avenue and see what we can get answered. All right?
Sure. Okay.
So the first question is about fertility. And the question is, how can women boost their fertility?
Well, number one thing, I guess, lifestyle, right? You want to maintain a healthy lifestyle and healthy weight. Eat healthy, but healthy means something different for each person, right? If you're eating vegan, it may be healthy for other reasons, but it may not be the healthiest diet for your fertility. When I say healthy diet, I mean a well-balanced diet. Making eggs is a building process, and building blocks is the proteins. And so we need building blocks. So we want our patients to have enough protein and enough calories so their bodies will be able to build healthy eggs. But at the same time, we don't want our patients to be overweight or underweight, both of which can affect the fertility. And other lifestyle issues like excessive drinking alcohol or tobacco products like smoking, cigarettes. And a lot of times patients don't even count vaping as a problem, but vaping is just as bad as smoking cigarettes, if not worse, because you can vape anywhere you like. That leads to doing a lot of vaping, a lot more than you could smoke cigarettes, right? So that's a potential problem. And it's been shown that tobacco products can damage eggs and sperm and makes the ovaries age much faster. So definitely I recommend women to stay away from tobacco products and vaping.
Okay. And so the next question is, how can men boost their fertility?
Same thing for men too. Healthy lifestyle, active lifestyle, regular exercise. It doesn't have to be anything excessive, or you don't even have to go to gym. Walking every day, at least 10,000 steps, is great for both male and female patients. Smoking is bad for sperm as well. Smoking cigarettes and vaping, it damages the sperm. It affects the shape of the sperm and the DNA quality in the sperm. And another issue sometimes we encounter is the workout supplements that contain steroids, androgens, or testosterone. That definitely affects the sperm production, decreases the sperm count significantly. So I tell my patients to stay away from workout supplements that contain steroids or androgens. And sometimes men are given testosterone cream or shots just because they have low energy or low libido. That's not a good thing to do while you're trying to get pregnant either.
Gotcha. And so actually interesting because you mentioned vaping, and when I saw you in 2017, I mean, vaping wasn't even a big thing. And so now we're seeing teenagers doing it, and even, middle-aged people doing it. So it's interesting that you would point out that people need to factor that in, because I think vaping was kind of brought out as, oh, this is a safer alternative to smoking. And we're seeing that it's not.
It's not, unfortunately. And I tell my patients, it's almost like cigarettes with filters, right? The cigarettes were bad, and then they came up with the filters, and they said, oh, this is filtered cigarette, it's not as bad. So vaping is a variation of that, and it's not any safer than smoking cigarettes.
Gotcha. And so when I came to you, I was just concerned because I was, approaching 35 and I just wanted to make sure everything is fine. And we went through some basic testing. Can you just walk us through, as far as for the woman, what is some basic tests that you do to check the fertility and whether or not they're ready to try to conceive?
There are four compartments that have to function normal in order to get pregnant. Number one is ovaries. Number two is fallopian tubes. Number three is the uterus. And number four, last but not least, is the sperm count or the testes, right? And the most important factor, to be honest, in today's world is the ovaries, the egg count or the age. They're all intertwined. A lot of my patients are over 35, and age is a big factor on the fertility. And the reason for that, we all are born with a finite number of eggs in our ovaries, right? Whatever you have at birth, that's all you're going to have rest of your life. We do not make new eggs after birth. So there is an age-related decline in the egg count, and after 35, usually it starts getting harder and harder to get pregnant every year. And that decline sometimes happens a little earlier in some women, and we don't know the reason. Sometimes we know if they're smoking cigarettes, for instance, or they received some sort of a cancer treatment like chemo or radiation, that could also diminish the egg count. So that's, in my mind, the most important factor is the egg count. And it's very easy to check with the current technology. There's a simple blood test called AMH. And AMH is a hormone made in the eggs only in our bodies. No other cell type makes AMH. So if a woman has good number of eggs, their AMH levels are high. When they start running out of eggs, then the AMH levels go down.
Gotcha. And then also, I think you, when we went to see you, we did my husband's sperm count, and we also were looking at motility and quality of the sperm. But I also did, and I can't say the word, the dye test with the for the fallopian tubes too.
HSG
to
test.
check on
That's
the
correct. So after checking the ovaries, right, we also check the fallopian tubes and the lining of the uterus. I do a test called HSG, or hysterosalpingogram, or dye test, where we inject dye into the uterus and the tubes, and we take X-rays. And we can see the lining of the uterus, and we can see the tubes, fallopian tubes, and we can see the dye coming out of them. And that's another basic workup I pretty much do on every patient. And then, of course, the sperm test, right? That's an easy test to do. And we check the count, movement, and the shape of the sperm, and have an idea about a fertility potential of a male patient.
Okay. What was interesting to me too was like all the myths surrounding the HSG, and everybody was like, yeah, once you have it done, then everything's cleared out. And I was like, well, I hope so.
Yes, I mean, there are studies that show that the pregnancy rates are higher right after an HSG test, right?
Yeah. So in my experience, it was. So.
It was. It worked for you. I'll take the credit for it.
Yeah.
But yeah, it happens. Sometimes patients get pregnant right after the HSG test. It can happen. We don't know exactly why, but we say maybe it flushes out the tubes and cleans them out, and it works. Maybe patients time intercourse much better in that month, since HSG is done on a certain cycle day. They know what's going on that month, and maybe they do they have timed intercourse in a much better way, and patients get pregnant at a little bit higher rate than the patients that don't have the HSG.
Yeah, and also for me, what was interesting, I started my cycle as a teenager, but I always assumed a cycle was 24 days, that you ovulated, 28 days, you ovulated at day 14. And when I started to track that, I actually realized I was ovulating very early in my cycle, like around day 10. So that was also an interesting observation where, people have these assumptions of what happens when, but if you're not actually tracking it, then you're actually not getting your numbers right. So even
Correct.
if you are not having trouble, it's just maybe sometimes a timing issue if they're not, having infertility issues.
Correct. Yeah, I mean, we all have to know our bodies and monitor, especially if we're trying to get pregnant. We need to monitor our cycles and even maybe do ovulation predictor tests to time intercourse much better.
Yeah. So the first question this person wanted to know is, what do you think causes recurrent pregnancy loss, and what are the basic statistics in the U.S.?
Well, I mean, the unfortunately, in most of the cases, we cannot identify a reason. First of all, about 15 to 20% of all pregnancies end with a miscarriage. So it's very common. And when there are hundreds of thousands of pregnancies every year in one country, then statistically, some patients will hit that 15 to 20% twice in a row, and they're going to have recurrent pregnancy loss. And what's the most common reason for pregnancy loss? It's genetic abnormalities or chromosomal abnormalities in the embryo. And so there are chances that a couple could hit that chromosomal abnormal embryo twice in a row if the baseline risk is 15 to 20%. But sometimes it becomes 3-4 times, and it could be still statistically just being unlucky. But sometimes we can identify reasons. Majority of the time, unfortunately, we may not be able to find a reason. What are the most common reasons or concrete reasons for recurrent miscarriages? Chromosomal abnormalities in the parents, right? In the male or the female partner. We call them balanced translocations. One piece of the chromosome breaks and goes and attaches to another chromosome. The patient is normal. The husband or the wife, female or the male partner, they're going to be normal because they don't have excess genetic material or missing genetic material. Just the location of a piece of genetic material switches from one chromosome to another. However, when we make eggs or sperm, only half of our chromosomes go into the egg or the sperm. So if the egg or the sperm gets the chromosome with the missing piece, that's abnormal. You're going to have a miscarriage. Or the egg or the sperm gets the chromosome with the extra piece, that's going to be an abnormal sperm or the egg also as well, and you're going to have a miscarriage. So in that scenario, 7 out of 8 pregnancies would end with a miscarriage. Only 1 out of 8 pregnancies would go to full term. Another reason is uterine shape abnormalities. Sometimes patients are born with a wall in the middle of their uterus. We call it septum. Septate uterus or uterine septum. That can also increase the risk for miscarriages, and it's easily corrected through surgery. It's a day surgery. We'll put a camera into the uterus and we can cut that wall, and the pregnancy rates improve significantly. And there are also some blood clotting disorders like antiphospholipid syndrome. They could be associated with recurrent miscarriages as well.
Gotcha. Interestingly too is like, I feel like, especially when I started, planning to conceive, I feel like the conversation about miscarriage is very hush hush, and a lot of people struggle in silence. And sometimes, like you said, it's just bad luck. It's, and then they go on and conceive and have other children and they never really talk about it. And so a lot of women, I think when they experience that, they think, oh, I'm 1 in like 200, but like you're saying, the numbers are probably higher. It's just like women don't feel that other people go through it because people don't really like to talk about it.
Yeah, it's a very hard experience to talk about. It's stressful, emotionally difficult time. A lot of times, you're right. People don't want to talk about it, and people don't want to. For that reason, people don't want to tell their friends or family members that they are pregnant until they know that they're not going to have a miscarriage.
Yeah. And that's a scary thing too, is, especially if you've experienced that in the past, being worried about revealing your pregnancy and sharing the news with people because you don't want to jinx yourself, like in my situation, I had to tell my job so early and my family didn't know for so long. And the reason I had to tell my job is because there were certain cases I couldn't do. And so I always had this lingering fear of like, what if something happens? Now these people know. It's definitely.
I mean, you tell everybody you're pregnant, and then you have to go back, circle around, circle back and tell everybody you're not pregnant anymore. You had a miscarriage. It's very hard to do. So I understand. I tell my patients, wait till they have a positive, heartbeat, and even then I tell them if they want to wait till the end of the first trimester, it's reasonable before they start letting everybody know. Just to make sure, the risk of miscarriage is, significantly down before they start telling everybody they're pregnant.
Yeah, and in our experience with you, you were very like you were cautiously optimistic. When I had my first pregnancy test, you were like, "Okay, come in, we'll do the ultrasound," and then you're like, "Okay, now let's wait to hear a heartbeat." And I will say, like, even that period, like every time you come in, you're like, "Is there a heartbeat? Is everything okay?" But we really felt reassured and supported, and that was important for us because we were older parents starting out, and we really didn't know anybody else that was going through that. So thank you for that.
Oh, you're welcome. I'm
So
glad I was able to do a good job.
you did. You did a great job. So the next question, this individual is asking about anovulation, and she says, "My doctor prescribed me Clomid for anovulation, but I'm so hesitant to take it because I'm afraid of side effects and such. Could you discuss the possible considerations when taking Clomid?"
Well, Clomid is one of the oldest fertility medications. It's been around since 1960s. So, if we had really significant side effects, we would not be using it, and we would know by now. It's not like it's a new medication. We started using it, 2 years ago. Therefore, we don't know everything about it. It's been around for a long time. And in medicine, I always tell my patients, before I do surgery or any kind of treatment, in medicine, there is no risk-free medication or surgery or procedure. Everything we do in medicine has benefits and risks. So we have to look at the benefits and risks, and if the benefits outweigh the risks, then it's okay to do that treatment, no matter what it is. And Clomid is no different than that, and Clomid has side effects too. What are the most common side effects? The most common textbook side effect is hot flashes. In 10% of the patients, they can have hot flashes. But the most common side effect my patients complain is the mood changes. Fortunately, these issues are temporary and they go away. Some of the patients also report, they gain a little bit of weight, but it's not a significant amount of weight. They're not going to gain 10, 15, 20 pounds. And all these changes are also temporary. Once they stop taking Clomid, they will go away.
Okay. The next topic I wanted to talk about a little bit was the pre-implantation genetic testing. And what does this actually entail? And do you recommend it for all your patients, or some patients are higher risk and need to have done?
Yeah, so pre-implantation genetic testing, we do it when we do in vitro fertilization or IVF. Basically, we do a biopsy procedure on the embryos, meaning we take out several cells from each embryo and send those cells for genetic testing to find out which embryos have the correct chromosome count. Again, as I said earlier, most miscarriages are due to abnormal chromosome count in the embryo. And most failures when we do IVF and fertility treatments are due to chromosomal abnormalities in the embryos as well. So finding out which embryos have the correct chromosome count improves the pregnancy rates, and also eliminates unnecessary embryo transfers, and lowers the miscarriage risk as well. Therefore, I recommend pre-implantation genetic testing to all my patients to determine which embryo to transfer. And that allows me to transfer a single embryo rather than putting 2, 3 embryos in without knowing which ones are actually genetically normal and which ones are not. So that improves the chances of pregnancy per embryo transfer significantly. And it also lowers the multiple pregnancy rates. And I know a lot of my patients prefer having twin pregnancies, but I tell my patients we have to have one healthy baby at a time, because a singleton pregnancy has a much better risk profile than a twin pregnancy. Twin pregnancies are high-risk pregnancies for the mother and the babies.
Okay, so my next question is about IUI, intrauterine insemination. What patients are good candidates for this procedure, and what are the benefits of getting IUI?
So it's one of the first line treatments we use, inseminations, and frequently we combine it with a pill like Clomid or letrozole. An ideal patient is a patient who has unexplained infertility. All those tests I mentioned earlier, we did those tests, and they all came back normal, but we don't know why the patient is not getting pregnant. Then we recommend ovulation induction with Clomid or letrozole, along with intrauterine inseminations or IUIs. IUI is a simple procedure. We get the sperm sample, we wash it, try to get only good quality moving sperm, and then we inject the sperm into the uterus at the time of the ovulation or the day of the ovulation. It's a simple procedure. It takes me less than a minute to inject the sperm into the uterus. We do it in a regular exam room. After the insemination, patient lays down for 10 minutes and they get up and leave. They don't have to do anything special. They go back to their normal lives. Of course, we tell them, take necessary precautions like you're pregnant. But other than that, they don't have to do anything special. So patients who have mild sperm problems, patients who have unexplained infertility, and patients who have ovulation problems can be candidates for inseminations.
Okay. And what's the average number of IUI cycles, like, I guess, your patients have to go through in order to conceive?
Usually 2 to 3 cycles.
Okay.
We don't want to do more than 5 cycles because after the 5th cycle, the pregnancy rates are really low. Keep doing the same thing, expecting a different outcome is not the right way to go about, in fertility and anything in life, right? Yeah. If it's the right treatment for the patient, usually it works in the first 3 to 5 cycles or attempts. And if the patient is not pregnant after the 5th one, I think it's time to look into other options.
Okay. And so we're going to go on over to IVF because we have a lot of questions on this one. Yeah. Please walk us through an IVF cycle. Like, what happens from the beginning until, I guess, you implant the embryos?
So the way I practice is I do pre-implantation genetic testing on all of my patients. So when you factor that in, it comes with frozen embryo transfer as well. So from beginning of the injectable medications to extract the eggs to the embryo transfer, it's about an 8-week process. The first 2 weeks is the most intense time where we need to see the patient every 2 to 3 days. They start injectable medications. There are superficial shots like allergy shots or insulin shots. We teach the patients how to do the shots. The needle is very small since it's a very superficial shot. And they do these shots, 2 to 3 shots every night for about 10 to 12 days. And during that time, they come to the clinic every 2 to 3 days to do ultrasounds and blood tests to monitor the egg growth or follicular growth. Once the follicles or the eggs reach the size we like, then we give one last shot to trigger ovulation. And exactly 36 hours after that trigger shot, we extract the eggs out. And how do we extract the eggs? It's a minor procedure. It's transvaginal, ultrasound-guided needle aspiration. So we give our patients anesthesia. They don't feel anything. They don't remember anything. It takes us about 15, 20 minutes to extract the eggs. That day, we also need the sperm. That's the only day we need the sperm, actually. And also, we need the husband to drive their partner home, right? Yeah. Other than that, we don't really need the guys. So we inject the sperm. I hope they're not going to be mad at me for saying that now. No. But anyway.
Well, they'll be needed when the baby gets there.
Yeah, so exactly. We inject the sperm into the eggs that day, and we let the fertilized eggs grow in the lab for about 5 to 6 days. When they reach the day 5 embryo stage or blastocyst stage, then we do that biopsy procedure on them, meaning we take out several cells from each embryo, freeze the embryos, and send the cells for genetic testing. And we wait for a week or 2 to get the genetic test results. And once we know which embryos are genetically normal or correct chromosome count, then we prepare the uterus for the embryo. We cannot put the embryos into the uterus anytime we like. We have to put the embryos into the uterus during the implantation window. If we put the embryos into the uterus at a random time, even if you put 10 embryos in, you're not going to get pregnant. So how do we prepare the uterus? It takes about 19 days to get the uterus ready for the embryo, 12 to 14 days of estrogen, either estrogen pills or estrogen patches, followed by 5 to 6 days of progesterone, usually progesterone shots, and then we thaw one embryo and inject it into the uterus.
And so I've heard those shots, like you have to get them at a specific time every day.
Yeah, usually in the evening, but it doesn't have to be like if you start doing them at 7 p.m., you have to do them at 7 p.m. every day. I mean,
Gotcha.
it can be a little early, it can be a little late, but the most important shot is the trigger shot. We definitely want you to do it at the right time because that determines what type of eggs we're going to get. If you go in there to get the eggs too early, then we're going to get a bunch of immature eggs. If we go there too late, the eggs will be released from the ovary. We're not going to get any eggs. Even then, 15, 20-minute difference in the timing is not going to be end of the world, or even 30 minutes. But, we want to know if you're 2 hours late to do your trigger shot.
Okay. And what is in that shot? Sorry, what's that
What's
shot
that?
again? What's the name of that shot?
Trigger shot, it's HCG. It basically mimics the body's own LH surge, which starts the ovulation process. So we use HCG to achieve that.
Okay. One of the questions, and some of these are acronyms that I don't really understand, but I know you know what they are. So this one person wants to know, if you're going through IVF, what's a better option, an FET or fresh?
Yeah, I mean, frozen embryo transfer. FET is frozen embryo transfer versus fresh. It depends on how you do the cycle. Right now, greater than 90% of the IVF cycles I do are FET or frozen embryo transfer cycles, for obvious reasons, because I do pre-implantation genetic testing and we freeze the embryos. And at the end of the day, we know which embryo has the best chance to achieve pregnancy, rather than trying to put the first embryo we see into the uterus in a fresh cycle.
Gotcha.
So I like frozen embryo transfers for a couple of different reasons, and one of them is the selection of the embryos.
Okay. And one question that the other person asked is, what is the likelihood of having birth defects with an IVF conception?
With IVF, so when we do IVF, we also use intracytoplasmic sperm injection, ICSI. That improves the fertilization rate significantly, and also it's helpful when we do the pre-implantation genetic testing. So when you look at the data in IVF babies that were conceived through IVF and ICSI, there may be slight increased risk in the birth defects. Even if you get pregnant naturally, your risk of having a baby with a birth defect is about 3%. So with IVF, that could be 4 to 5%. But we also have to understand IVF patients, the couples that need IVF or patients that need IVF, it's hard to compare them to the general population. We have to understand that egg quality, sperm quality are different than the general population. Age is different. So all those factors actually can increase these risks as well. And with ICSI, there are some reports that some rare imprinting disorders like Angelman syndrome or Beckwith-Wiedemann syndrome, the risk for those may be elevated, but the risk for those in the general population is 1 in 15,000. And if you do ICSI, that risk is increased 5-fold, but that means it goes to 5 in 15,000. So when you look at the absolute number, it's not a significant increase. And there were some reports that also show that X chromosome abnormalities, XY chromosome abnormalities may be increased in ICSI pregnancies. However, when we do ICSI, frequently the sperm quality is really poor. So we don't know whether those abnormalities are due to the poor quality of sperm or eggs we use, or because of the technique itself. But doing pre-implantation genetic testing on the embryos would eliminate those chromosomal abnormalities. So again, in medicine, there is no risk-free treatment, and IVF is not different than any other treatment either. So there are some risks associated with IVF, but the benefits definitely outweigh the risks, and the increased risks are not, when you look at the absolute numbers, are not like 70% or 80%, it's a lot less than that.
And what does ICSI stand for?
Intracytoplasmic sperm injection.
Okay.
So we select a single sperm and inject it into the egg.
All right. Okay, so we're going to go on to egg freezing. This was
Yeah.
actually, I got a lot of questions on this one. I think part of it too is I think moms are waiting longer to have babies, and especially women in the medical careers. I think, you know, they're trying to go through training and try to finish all of that and then have kids. And so some people feel like, you know, they're behind. And I always tell people, like, you're on your own schedule. Like, you're not behind because you're really running on your own schedule. But I do understand the thought process behind it. So the first question is, how old is too old to harvest eggs? Of course, before menopause, but is there research that gives an age range?
No, I mean, there's no age range like that. There's a research like that, but we know that fertility is better if you're younger, right? So
Yeah.
I'd like to freeze your eggs when you're 30 rather than when you're 40, of course. You know, the chances are going to be much better if you're 30. But, you know, 40 is not late either. The oldest patient I had was 42. She had 2 egg freezing cycles, one at age 41, and a few months later, she turned 42 and we did another cycle. And you know, we were able to get about 20 eggs. And a few years later, actually 4 years later, when she was 46, she came back to me to use those eggs. Out of about 20 eggs, we were able to get one genetically normal embryo, and she has a daughter now.
Oh,
So
awesome.
there's really no cutoff. You know, yes, if you're 45, I'm going to tell you the chances are extremely low. You should not do that. But if you're 38, it's not too late. If you're 40, it's not too late. When do I want to see? Yeah, younger the better, you know, because my success rates will be better. Your success rates will be better. But I cannot tell every 25-year-old to freeze their eggs either. So it really depends on the patient's situation too. If you're in a stable relationship and they're planning to have a baby in a year or two and they're only 30, they don't need to freeze their eggs. But you know, if they're 30 something and they have no plans of having a baby in the next 5 years, then I don't think it's a bad idea to freeze their eggs at that point.
Okay. And how many eggs can you harvest in one treatment?
As many as the ovaries allow us. It will depend on the ovaries. There isn't a certain dial, like I can turn it to 5 eggs, 10 eggs, or 20 eggs.
Okay.
We are greedy. We'd like to get as many eggs as possible so we improve your chances in the future. But it will be determined by the eggs, the ovarian reserve, or the AMH level that I mentioned, that hormone at the beginning of our conversation. AMH determines the ovarian reserve or the egg count, and it correlates best with the number of eggs we will get when we do IVF or egg freezing.
Okay. And what happens to the eggs that you don't utilize?
In what scenario? I guess, you know, we freeze everything and embryos as well, and we keep them frozen until the patient is ready to use them. We'd like to know what the patients want to do with those by the time they turn 50.
Okay.
Theoretically, they can keep them frozen for decades, and there are, you know, private storage facilities. They can transfer their eggs, sperm, or embryos to a private storage facility and keep them there forever if they like.
So it's really whatever you want to do with it. I guess same thing with the IVF embryos, right? It's really
Correct.
the patient's.
Yes.
And
Yes.
how much does this process cost on average?
Egg freezing is going to cost several $1,000s. Probably it's going to range somewhere between $6,000 to $10,000, including the medications.
Okay. And what kind of important questions do you need to ask yourself before you go into this process?
I guess it depends on the patient. It depends on what they expect, what they want to achieve. Do they want to achieve fertility right now? Do they want to achieve fertility in the future? Are they trying to preserve their fertility? How soon they want to get pregnant? Where are they in their lives and their expectations?
And I guess the same thing you said, they also need to have a decision about what they want to have done with the eggs and the embryos, because that's totally up to them.
It is up to them, but you know, we don't do embryo transfers after age 50. Therefore, you know, if you want to use your eggs or embryos, we recommend you use it before age 50.
Okay. And what are the important questions you think that you should ask your practitioner or specialist if you're deciding to go through egg freezing?
I think we already discussed these. Where are you in your fertility? What's your AMH level? What's your ovarian reserve? Do you think one egg freezing cycle is going to be enough? Whether you need more than one? Sometimes patients have low AMH level, diminished ovarian reserve, and in one cycle we get only several eggs, 5 to 6 eggs. And in those patients, we tell them maybe we should do another cycle or two to bank more eggs to improve chances of fertility in the future. Again, we discussed the procedure. How long is it going to take to freeze the eggs? What are the risks? What are the chances of pregnancy in the future? And egg freezing process is, of course, shorter than the entire IVF cycle, because IVF cycle involves fertilization of the eggs, genetic testing of the embryos, and the embryo transfer. Egg freezing takes us only 2 weeks, and we're done.
Okay. And I guess this question, I feel like you answered it, but I'm still going to ask. She wanted to know, if you harvested, say, like in your 20s and you weren't ready until your 30s or 40s, do the eggs get weaker the longer they're kept?
Theoretically, eggs and embryos should be stable once they're frozen for decades. I think the only thing that gets to them when they're frozen is the gamma rays or something like that. So they should be healthy for a very long time.
Okay, and this kind of actually got me thinking about something. So can you use those frozen eggs for IVF or no?
Yes, that's what we do. We thaw the eggs and then inject them with sperm, and we get embryos and do the pre-implantation genetic testing on the embryos and transfer those embryos.
Okay. So next question, since your clinic covers a whole array of fertility technologies, what options do you offer single women who want to have a baby?
So it depends on when they want to have the baby. If they want to have the baby in the future, we recommend egg freezing. If they want to have a baby right away and they're single and they want to be a single parent, then we recommend a sperm donor, using donor sperm and inseminations. If everything is normal with them, their tubes are open, the uterus is normal, the egg count is good, they ovulate on their own, they can even just do a natural cycle insemination. They can track or monitor their ovulation using ovulation predictor tests, and the day of the ovulation, we can do an insemination using donor sperm.
Okay, and what options are available for LGBTQ couples?
Same, we can use donor sperm, we can use donor eggs. Sometimes we do reciprocal IVF, meaning we get eggs from one partner and transfer the embryos into the other partner. And so all these options are available to them. They can use donor sperm, inseminations, IVF, donor eggs for same-sex male couples, and with gestational carrier, of course. So all these options are available to same-sex couples and single parents.
Okay. And what are some things you should consider when choosing donor sperm? And does your clinic offer options for donor sperm?
We use national sperm banks, and sometimes I joke with my patients, it's probably safer to get your sperm from a sperm bank than meeting somebody at a bar, because these samples are tested. Nowadays, it's routinely, they do genetic testing, carrier screening. So they screen the donors for genetic diseases to see if they carry any genetic diseases. They screen them for infectious diseases. They get medical history. So we have a lot of information about these donors. And you just have to make sure this sperm bank you're using is an accredited sperm bank, and they do FDA required testing on the donors.
Okay, so we're going to move on to a totally different discussion, and this one is about oncofertility. So for people who have faced a cancer diagnosis, or even in the case of people with BRCA mutation, how much time do you have to make that decision about whether, if you're diagnosed with cancer, how much time do you have?
Well, that timing is really tight because oncologists and the patients want to start their cancer treatment as soon as possible. But usually there is still a few weeks, the cancer diagnosis, testing and getting everything ready and starting chemo and radiation may still take a few weeks. And it only takes us 2 weeks to freeze the eggs. For these patients that cannot wait, I do random start egg freezing or embryo freezing cycles. So normally we always wait for the menstrual period to start the treatments, but I know these cancer patients don't have time to wait for 2 to 3 weeks to start their next period to for egg freezing or embryo freezing. So as soon as our policy is to see these patients within 72 hours. As soon as they're diagnosed and they call us, we get them in within a day or two and get their testing done, necessary testing done. Infectious disease testing is required by FDA before we do egg freezing or IVF. Whatever is necessary, we do it right away and order their medications and start their egg freezing or IVF cycle right away. So within a couple of weeks, we can extract the eggs and the patients can go back to their oncologist and start their cancer treatment.
Gotcha. So the question I have, I guess, is now that we're going through like COVID and there's like, how I guess are your patients faring with that? Because I know we have a friend who they're going through this process and a lot of stuff got delayed with the elective procedures. And so how are you guys able to like still get the patients to get the treatments and in a timely fashion?
We had to stop doing treatments in March and April as well. But since May, we were allowed to do office-based procedures in the county where we are. So we continue to do our fertility treatments. There was some delay in March and April, but since then, there is minimal delay, to be honest.
Okay. And the other question, which is actually my final question as far as the fertility question is, so I know recently like reproductive medicine has gotten some negative press and some of it is old press. Like I think there was a podcast that came out about a physician who was telling patients they were getting donor sperm and he was using his own sperm. And how do you reassure the patients that like you're doing things the right way? Like how do you help them, because like these patients assumed they were getting sperm from medical students and they weren't. How do you assure your patients?
I mean, it's a very hard thing to do in today's day and age, right? I mean,
yeah.
You have to, I don't know whether this is going to be politically correct, but you have to be a crazy person to use your medical student sperm or your own sperm today, right? It's not going to happen. We cannot do that. This is my passion, is to help the patients, is not to hurt the patients. And it's not a smart thing to do for ourselves either. Yeah. I think patients should not worry about that. I mean, these are very rare examples and everybody I know in our specialty would not do such thing. I don't think I would worry about, a doctor using their sperm or picking, some random medical student and using their sperm. I mean, we don't provide the sperm, to our patients. We actually, use the sperm banks and we ask the patients to purchase it and send it to us. So there's no incentive for us to use some other sperm than the sperm patient purchase.
Yeah, that particular physician was actually very.
Oh, crazy. Sorry, you're breaking up.
Oh, can you hear me now?
I can't hear you.
Uh-oh.
Hello?
Hello, can you hear me?
I can hear you now.
Oh, okay, I'm sorry. Yeah, I said that particular physician, it was a very crazy story and all these kids found each other on Facebook. It was actually very insane. But yeah, I actually listened to the whole podcast.
I read those stories. I mean, yes, I think that doctor was in Canada, I believe, and I read the story.
This guy was here in the U.S. and I forget.
In the U.S. Yeah, maybe in the U.S. somewhere, yes, and yes, and I think one of the patients, noticed the resemblance between them and the doctor. I mean, I don't know. I just can't wrap my mind around it. I mean, why a physician would do such thing is
Yeah.
it
Well,
should
I
not
think they
exist.
all came to the conclusion that he was trying to play God and he wanted to basically, I guess, have all these kids, but they actually wanted to kind of have some connection with him and he didn't want to have a relationship with them. So it was very odd.
It is very odd.
Yeah.
I mean, I can guarantee you there's not going to be many examples of that, fortunately.
No, not in our current society. Okay, so to end the recording, we're gonna go through. I have a list of 5 questions that I ask all my my interviewees, and it's really fast. You just give me one line answer, one sentence answer. So, are you ready?
Yes.
All right. How I'm changing women's lives.
Repeat it again.
How are you changing women's lives?
Helping them achieve their dreams and complete their families.
All right. One word to describe your journey.
Joyful.
Joyful. What is self-care to you?
Taking care of my health for my patients.
All right. Who is your role model?
Oh, probably my father.
Awesome. What is your big scary goal?
I don't think I have a scary goal.
What is your big goal?
To be a good parent to my kids.
Awesome. All right. I think you're doing a great job so far. You made it what? How old is your oldest one?
10.
10. Yeah, you made it 10 years. I think you're doing a decent job.
Yeah, I was able to keep him alive for 10 years. So
10 years.
it's a great accomplishment.
When Isabella turned 1 and I was like, are we going to have a party? And I was like, you know what? It's a survivor party. We survived 1 year. We kept her alive. Yeah. We have to celebrate. So we did. And we which was good because this year we're not really going to do much. So
yeah, unfortunately, because of coronavirus. Yeah.
Thank you so much, Dr. Kovanchi, for being on here with us and answering all these questions. I'm pretty sure I'll have many more in the future. And I just want to say thank you so much for your time because I know you're a very busy guy and taking the time out really meant a lot to me. So thank you.
Thank you.